హలో అండి, అందరికీ నమస్కారం. ఈ ఇయర్ మేము బెటర్ బర్తింగ్ ఎక్స్పీరియన్స్ కాన్ఫరెన్స్ కండక్ట్ చేస్తున్నాం. ఐ థింక్ మీరు అందరూ చాలా మటుకు ఫస్ట్ ఇయర్ మనం 2023లో చేసినప్పుడు కూడా ఉన్నారు. సో ఈ ఇయర్ థీమ్ రీఇమాజినింగ్ చైల్డ్ బర్త్ అంటే కాల్ ఫర్ చేంజ్. అంటే మనం ఎలా చైల్డ్ బర్త్ ప్రాక్టీసెస్ని న్యాచురల్గా తీసుకెళ్ళగలము, ఎందుకు ఈ మధ్యలో ఇంటర్వెన్షన్స్ ఎక్కువైనాయి, ఎందుకు సిజేరియన్ సెక్షన్లు ఎందుకు అయ్యాయి, ఎందుకు ఫ్యామిలీస్లో ప్రెగ్నెన్సీ అంటే భయం ఉంది. సో ఇవన్నీ అడ్రస్ చేయడానికి, మళ్ళీ రీథింక్ చేయడానికి మేమందరం కలిసి ఉన్నాము. సో ఈ కాన్ఫరెన్స్లో స్పెషాలిటీ ఏంటి అంటే ఇట్ ఈస్ ఓన్లీ నాట్ ఫర్ డాక్టర్స్. ఇందులో డాక్టర్స్, మిడ్ వైఫ్స్, నర్సెస్, చైల్డ్ బర్త్ ఎడ్యుకేటర్స్, హెల్త్ కేర్ ప్రొవైడర్స్ ఎవరైనా సరే అటెండ్ అవుతున్నారు. సో దట్ అందరి ఎక్స్పీరియన్సెస్ షేర్ చేసుకొని ఏవైతే చేంజెస్ చేయగలమో వీఆర్ డిస్కసింగ్. సో ఇందులో వేరియస్ టాక్స్ ఉన్నాయి. మనకు ఆస్ట్రేలియా నుంచి స్పీకర్స్ వచ్చారు, డాక్టర్ కర్స్టన్ స్మాల్, ప్రొఫెసర్ హ్యానా డాలన్ వీళ్ళు వచ్చారు. సో వాళ్ళ ఎక్స్పీరియన్సెస్ మనతో ఎలా షేర్ చేసుకుంటున్నారు, అక్కడ వాళ్ళు చేస్తున్న ప్రాక్టీసెస్ ఏంటి, సో మన దగ్గర వాళ్ళ దగ్గర బర్త్స్లో డిఫరెన్సెస్ ఏమున్నాయి, సిజేరియన్ సెక్షన్ రేట్స్ ఎందుకు మనకు చాలా ఎక్కువ ఉండి వాళ్ళకి తక్కువ ఉన్నాయి, వాళ్ళకు మిడ్వైఫరీ కేర్ వల్ల ఎలాంటి ఉపయోగాలు ఉన్నాయి, మనము మిడ్వైఫ్స్ని ఎలా ఇంక్రీజ్ చేయగలం ఇన్ నంబర్స్, అవన్నీ డిస్కస్ చేసుకోవడం.
After women and the newborns in labor, what can we do to bring in the midwifery philosophy of care? So natural birthing, looking at a birth as a normal physiological event rather than a medical. For women who need a cesarean section, they need to get it timely. But for all the other women that can birth naturally, systems to strengthen this philosophy has been discussed in these 2 days. And healthcare professionals, including doulas, doctors, and nurses and midwifery practitioners are all here today and working as a collaboration. It's not just one cadre that's going to bring this. It's a systems approach and collaborative care that's going to impact on women and newborn in this country. Thank you.
I don't know how many of you are fathers in this group, but if you go home and ask your wives, they will tell you that they remember every detail of their birth, labor, and birth experience. So it's so important that a woman, whether she has a normal birth, a cesarean, or sometimes may need help with an instrument, but how was she made to feel during that whole period when she was in labor, when she gave birth to her child? That's going to affect her for the rest of her life because these memories stay with her. And if she is treated with kindness, respect, compassion, we are talking about competence being the baseline. It's a given. Safety is a given. But along with that, if all this is also offered by the staff and using evidence-based practices, a simple thing like when a child is born, giving that baby to the mother, allowing the baby and encouraging the mother to hold that baby skin to skin is one of the simple evidence-based steps during a birth. And that itself encourages breastfeeding, lactation problems are removed, bonding between mother and infant is established. And this can be done even during a C-section. So the whole experience has long-term effects, mother and child bonding, mother's emotional and well-being, psychological well-being, and also cognitive effects on the baby. When you have this incredible experience of mother and newborn not being separated. That's why the theme of the conference, or the conference, is labeled as Better Birth Experience. We're not here just for normal births. It's the whole experience of labor and birth. And Indy and my colleague, Dr. Pallavi, have said it's collaborative. So midwives and obstetricians work together. We need each other. And when we work together with other disciplines, keeping the mother and the baby at the center, the mother gets the benefit. She gets the care she needs.
ఈ కాన్ఫరెన్స్లో 2 రోజులు మన కాన్ఫరెన్స్ ఉంది. ఫస్ట్ డే ఇవాళ ఏదైతే ఉందో ఇవాళ వర్క్ షాప్స్ చేస్తున్నాము. రేపు టాక్స్ ఇంకా ప్యానల్స్ ఉంటాయి. ఈ వర్క్ షాప్స్ మొత్తం 6 వర్క్ షాప్స్ ఉన్నాయి. మార్నింగ్ 9కి స్టార్ట్ చేసాము, ఈవినింగ్ 5 వరకు ఉంటాయి. సో ఈ వర్క్ షాప్స్లో డిఫరెంట్ టైప్స్. ఫస్ట్ది ఆప్టిమల్ బర్తింగ్ పొజిషన్స్, అంటే మనకు ముందు నుంచి తల్లి అలా ఫ్లాట్గా పడుకొని ఉండి డెలివరీ అవ్వాలి, ఇంకా వేరే ఏ పొజిషన్ లేదు, ఒకటే పొజిషన్లో డెలివరీ అవ్వాలి, మూమెంట్ లేకుండా ఉంటుంది లేబర్లో. సో ఇలాంటివన్నీ డిస్కస్ చేయడానికి ఫస్ట్ వర్క్ షాప్ ఉంది. దాని తర్వాత హైడ్రోథెరపీ, అంటే పెయిన్ రిలీఫ్, అంటే ప్రెగ్నెన్సీలో పెయిన్ అంటే ఓన్లీ ఎపిడ్యూరల్ ఇవ్వాలి, లేదంటే ఏదైనా ఇంజెక్షన్స్ ఇవ్వాలి కాకుండా వాటర్తో కూడా పెయిన్ రిలీఫ్ ఉంటుంది అని ఒక వర్క్ షాప్ ఉంది. ఇంటర్మిటెంట్ ఆస్కల్టేషన్, ఇది ఏంటి అంటే మనము ఇప్పుడు సైన్స్ అడ్వాన్స్ అయ్యే కొద్దీ మనం పరికరాలు ఎక్కువ వాడుతున్నాం. అంటే కంటిన్యూస్గా సిటీజీ మషీన్స్ వాడడము, దానివల్ల సిజేరియన్ సెక్షన్స్ ఎక్కువ అవ్వడము. సో లో రిస్క్ మదర్ అయినా హై రిస్క్ మదర్ అయినా ఒకటేలాగా చేస్తున్నాం. సో ఈ ఇంటర్మిటెంట్ ఆస్కల్టేషన్ అంటే లేబర్లో ఉన్నప్పుడు తల్లిని ఇంటర్మిటెంట్గా హార్ట్ బీట్ ఎట్లా చూసుకుంటూ మానిటర్ చేయొచ్చు. ప్రతి ప్రెగ్నెన్సీకి ప్రతి లేబర్కి కంటిన్యూస్గా మానిటరింగ్ చేసి సిజేరియన్ సెక్షన్ రేట్లు పెంచాల్సిన అవసరం లేదు లాగా. సో ఇంకా ఒకవేళ బిడ్డ పొజిషన్ కనుక హెడ్ డౌన్ పొజిషన్ లేదు, వేరే పొజిషన్లో ఉంది అంటే మనం ఏదన్నా ఎక్సర్సైజెస్ చేసి ఆ పొజిషన్ని మార్చొచ్చా, అదొక వర్క్ షాప్ ఉంది. తర్వాత లేబర్ రూమ్లో కానీ ఓపీలో కానీ తల్లికి తర్వాత డాక్టర్కి కానీ మిడ్వైఫ్కి కానీ కమ్యూనికేషన్స్ ఎలా ఉండాలి, ఎలా అయితే వాళ్లకు మనం అంతా ఇన్ఫర్మేషన్ ఇవ్వచ్చు, ఎంత ట్రాన్స్పరెంట్గా ఉండగలము, అవుట్కమ్స్ దానివల్ల ఎలా బాగుంటాయి అనేసి ఈ వర్క్ షాప్స్ అన్ని చేస్తాం.
Education for our obstetricians and our healthcare professionals on how women can birth differently. So the first workshop was very much on standing up and getting different positions and how it actually aids the baby to be birthed. It's a really important workshop because with the training, it develops confidence, and healthcare professionals who are involved in birthing can bring in this respectful side of birthing for women, because birthing on the backs is very uncomfortable and it actually prolongs labor. So the other workshops that we've had is also on respectful care and how we can improve the environments of women birthing as healthcare professionals, how our own attitudes and our language impact on women birthing. So it's really important for us to be sensitive, to show empathy, because all of our actions actually impact on women birthing. And the third thing is having different options like birthing in water or using water as a form of pain relief actually helps women to be comfortable, to be soothed in their labor. It helps their contractions and it gives them a positive birth experience as well. But the workshop also shows who can birth safely, how can you provide that. And the fourth one is on listening to women with intelligent intermittent auscultation. As healthcare professionals, when we listen in at the right time, we can then detect when a woman then needs help. And this is really important because it's not just putting a woman on a monitor, because that limits her mobility. However, listening to the baby's heartbeat at the right time actually gives a whole surveillance on how well the baby is doing, and it gets the right action when we need to then collaborate and escalate it timely to an obstetrician if we are concerned.
Question: birth has not changed for the last I don't know how many million years. Women birth the same way. But what we've learned and what we need to remember is over the last probably 60 to 70 years, doctors have taken over birth and we've made it comfortable for ourselves, but not left it to women to birth naturally. That's the problem that's happened. So what we are doing today is just reminding all healthcare providers, including obstetricians, that we need to stop and think, step back, and review the childbirth practices today. We've become very interventional. We're doing things that are not necessary. A simple example, by starting an oxytocin drip where it's not required. by inducing labor when it's not required. So, why do we work midwives and doctors? Because that portion of women who are healthy, have no complications, should be encouraged to set into labor spontaneously and encouraged to birth. And all this is combined with giving the woman knowledge, preparing her through childbirth classes, involving the husband so he takes responsibility. You have a section of women who have some medical complications, and that's where the doctors work with midwives together. And if that woman needs a cesarean for a justifiable cause, or she may need further support, let's say a diabetic on insulin, or she may have a surgical problem where you work along with other disciplines, and then you decide the mode of delivery depending on the need. So it's not so much of newer techniques, but it's a question of evaluating what we are doing today, going back to what should have happened over these years. Like if a woman, if you leave her alone, she sits into labor and you encourage her, you monitor her, she may on her own actually tell you, I want to walk around. She on her own may say, I can feel the baby coming and I want to squat. She may even tell you, I want to lie, I want to be on my knees in the knee chest position because this is the best I feel I want to do. So instinctively, she responds. And that is what we've removed. Thank you. I hope when women birthed at home, there were more normal births, and the ones who had complications were brought in. After World War II, America and the Western countries started building hospitals. So women started coming into hospitals to birth. And that's when things changed, because now doctors began to see women in hospitals, and we began to change birthing practices to suit the doctors. So if you've got volumes and you've got fewer doctors, fewer beds, it's like a conveyor belt. You want to birth women quickly, so you start interfering. That's the mistake we've made over the last 60 years. Now, why are C-sections going up? There are many, many reasons for that. One of the reasons is said it's possible that you charge more and you're possibly making more. I'm not so sure how many would actually subscribe to that. I'm of the firm belief that if we change our practices, unlearn a lot of things that we've been taught, which we know today are not correct practices, work along with midwives, then definitely you'll have more women birthing normally and less women needing a cesarean.
Called a low risk and certain group called a high risk or a moderate risk. So you always have to see which group needs what. If it's a low risk woman, they really don't need a doctor. A professional midwife is equivalent to a doctor in taking care of her without intervening. And then the doctor can take care of a high risk pregnancy. We are not saying that everybody should do the same thing as is told in the workshop. This is for low risk mothers who do not really require anything but proper care in labor. You really do not have to induce a low risk mother without any problem. You really need not do a cesarean section without an indication. We're not saying that it is not possible to have a zero cesarean section rate any which ways. It always depends on why we are doing and what is the indication. So doing that correctly is the right thing. So whenever there's a group of women coming to the hospital, when you triage them into low risk, moderate risk and high risk, then you know where your cesarean sections are high. Supposing you understand that the low risk women have higher cesarean section, that is where you start working backwards to see we could have given her a vaginal birth and where we had gone wrong kind of a thing.
How many what was the total number?
Here for this conference. So for the main conference, no, this is a 2-day conference. For workshops, we have limited it to 100 to 120 because workshops are all hands-on. We cannot have a big group attending workshops. So it has been divided into two groups, 50 each in each group. And tomorrow for the conference, we are expecting 300 delegates. And this is a mix of doctors, nurses, midwives, doulas, childbirth educators, physiotherapists. So it's a mix of groups. That's when the discussions start. If it's only a doctor-led conference and only doctors are attending, you really don't know what others are thinking. So this gave us a platform to really encourage everybody who's taking care of the mother and the newborn to come and discuss and share ideas, question things, challenge the old practices and challenge the practices that have been going now. It's a healthy discussion. That's where we come into conclusions and say that yes, we can change here.
You'll wonder why physiotherapists are here. Quite a few pregnant women experience backache or severe pain in their various parts of the body. So one is a physiotherapist helps the woman cope with that. But more importantly, what we discovered at Fernandez, there are women who have musculoskeletal problems. Or I could think of a woman who had polio, and so one leg was shorter. She had a very distinct limp, and she was pregnant for the first time, very, very keen to have a normal birth. She had gone to many other hospitals, and she was told that she'll need a cesarean. So she came to us. Then we worked with our physiotherapists. We worked it out. And that woman birthed normally, but she stood and birthed. And this was because we worked collaboratively. Midwife, doctor, physiotherapist, working out the logistics. And that woman was ecstatic. She said, "My dream has come true." Now, if we did not have this attitude, she would have, I'm sure even we would have done a cesarean. It's because we stopped, we looked at the evidence, we realized that our childbirth practices at Fernandez needed to change. And that's why we're so committed to better birth experience.
Discuss both the clinical audit as well as the women's experience part of it. So we have done two of them. For the clinical one, what we did, we took out the 11 years data and we checked all these 100,000 women who birthed with us and divided them into low risk and high risk. And we looked at low risk mothers as such, who were taken care by the midwives and who were taken care by the doctors. So when we analyzed this data, we realized that in the doctors group, the interventions were more, like giving a cut called episiotomy or, the skin to skin contact, that was less. So delayed cord clamping was less. So there was, these two groups were divided. So in these two groups, we found that there was a major difference, which is statistically significant. This is for low risk mothers, I'm not saying it's for entire population. That's where we realized that probably the low risk mothers are better in hands of a midwife than in hands of a doctor.
Definitely.
Is that at some point of time we realized that we were not listening to what mothers were feeling. So once they birthed, we started giving them out the experience-based audit questions and asked them, how was your experience during labor? Was care provided? So we saw that there was little changes in answers when compared to induction of women versus spontaneous birth. So cesarean section versus a vaginal birth. So there's definitely a change in birthing experience because somehow they feel that we've tried for a long time, but still we had a cesarean section. Again, in that group, if it was communicated well, it was transparent and there was no doubts about the indication for a cesarean section, the unhappiness rates were very less because they knew everything. They're transparent. And you always have a birth companion with you in the labor room. And even when we do a cesarean section, the husband accompanies her into the theater. So for those things, we realized that the communication part and everything was fine. But when you look at the overall experience, obviously the low risk women were a little less satisfied when they had a cesarean section when compared to high risk women. High risk women were probably prepared that, I have so many medical problems, but they were very happy when they had a vaginal birth. So clinical and as well as experience outcomes is what we are looking at now, because we realized that we only looked at what we wanted to look at. We never looked at from their perspective. Now we started looking at from their perspective. Basically, I agree that diabetes and hypertension have been increased because when we also looked at our own data, which showed that 35 to 40% of them are diabetic and 70 to 18% of them are hypertensives. Again, all need not be high risk. If it's a diabetic woman with very well controlled sugars, then she's almost as good as a low risk mother. And if it's hypertension with very well controlled hypertension, is as good as the one that you're mentioning is severe preeclampsia, which may be almost around 3%. So those become high risk where you really, they have to be under care of the doctor or collaborative care depending on the situation. But not even them, you really need not have them have a cesarean section if there's a collaborative care. Even high risk mothers can be managed using, doctor and midwife can be together. We can collaboratively manage. And there have been many high risk women in Fernandez Hospital who were managed collaboratively and who had a successful vaginal birth.
Obesity.
Yeah, obesity. Even obesity is increasing for that sake. Women above 40 BMI have increased. So we started a body positive clinic where we look after women above 40 BMI. That is anything from 100 kilos to 160 kilograms, where these women are also high risk of having a cesarean section. But again, without any medical problems or with medical problems, these women can be managed collaboratively in labor and they can have a normal delivery. It's not that if you are obese, you should have a cesarean section. It's not that if you are having high BP, you should have a cesarean section. That's where midwives help with collaborative model of care. నమస్కారం, నా పేరు డాక్టర్ పల్లవి. నేను కన్సల్టెంట్ ఆబ్స్టిట్రిషియన్ని, ఫర్నాండెస్ ఆబ్స్టిక్స్ డిపార్ట్మెంట్కి హెడ్ ఆఫ్ ద డిపార్ట్మెంట్ అండ్ ఈ కాన్ఫరెన్స్కి ఆర్గనైజింగ్ సెక్రటరీని. సో ఈ ఇయర్ థీమ్ ఇస్ రీఇమాజినింగ్ చైల్డ్ బర్త్, కాల్ ఫర్ ఎ చేంజ్. అంటే ఈ బర్తింగ్ ఎక్స్పీరియన్స్ని ఎలా మనం తల్లికి బిడ్డకు ఫ్యామిలీకి సేఫ్గా చేయగలము, ఎంజాయబుల్గా చేయగలమని డిస్కస్ చేస్తున్నాం. సో ఏమేమైతే ఇంటర్వెన్షన్స్ మనము పెరుగుతూ వెళ్తున్నాయో, ఎలాగైతే మనకు సిజేరియన్ సెక్షన్స్ ఎక్కువ అవుతున్నాయో, ఎలా మనము చైల్డ్ బర్త్ ప్రాక్టీసెస్ని మళ్ళీ వెనక్కి వెళ్ళి రీవిజిట్ చేసుకొని జరుగుతున్న ఇంటర్వెన్షన్స్ని ఛాలెంజ్ చేసి, క్వశ్చన్ చేసి ఎలా వాటన్నిటిని తగ్గించి నార్మల్ డెలివరీలు ఇంప్రూవ్ చేసుకుంటూ ఆ తల్లికి ఆ ఫ్యామిలీకి మంచి ఎక్స్పీరియన్స్ ఇవ్వగలం అనేది దాని చుట్టూ, ఆ థీమ్ చుట్టూ ఈ వర్క్షాప్స్ కానీ ఈ కాన్ఫరెన్స్ కానీ అరేంజ్ చేయడం జరిగింది. సో ఇవాళ వర్క్షాప్లో 100 డెలిగేట్స్ ఉన్నారు, రేపు కాన్ఫరెన్స్లో 300 డెలిగేట్స్ ఉన్నారు. 2 ఫారిన్ స్పీకర్స్ వచ్చారు ఫ్రమ్ ఆస్ట్రేలియా. ఒకళ్ళు ప్రొఫెసర్ హ్యానడాలన్, తను చాలా సీనియర్ మిడ్వైఫ్. సో తన ఎక్స్పీరియన్సెస్ షేర్ చేసుకుంటూ తన టీచింగ్స్ మనతో షేర్ చేసుకుంటున్నారు. ఇంకొకరు డాక్టర్ కర్స్టన్ స్మాల్, తను ఒక ఆబ్స్టిట్రిషియన్. తను చైల్డ్ బర్త్ ప్రాక్టీసెస్ ఎలా జరుగుతున్నాయి, ఎలా మనం ఎక్కువ ఇంటర్వెన్షన్స్ చేసుకుంటూ కంటిన్యూస్గా బేబీ హార్ట్ బీట్ మానిటరింగ్ చేసుకుంటూ సిటీజీ ప్రాక్టీసెస్ ఎక్కువ ఎలా అయిపోయాయి, దానివల్ల సిజేరియన్ సెక్షన్స్ ఎలా ఎక్కువ అయ్యాయి, లో రిస్క్ మదర్స్ని మనం లేబర్ రూమ్లో ఇంటర్మిటెంట్గా హార్ట్ బీట్ వినుకుంటూ ఎలా మేనేజ్ చేయొచ్చు అని ఎవిడెన్సెస్ డిస్కస్ చేస్తున్నారు. అండ్ ఇవన్నీ ఎవిడెన్స్ బేస్డే ఉంటాయి, ఏది అలా పైన చెప్పడం కాకుండా ఎవిడెన్స్ బేస్డ్ ప్రాక్టీసెసే డిస్కస్ చేసుకుంటూ అలాగే వాటి వల్లనే న్యాచురల్ బర్త్కి ఎలా మనం హెల్ప్ చేయగలం అనేది థీమ్ ఆఫ్ ద కాన్ఫరెన్స్.